So now we're going to look at the parameters for the different types of conditions. And I think what happens is we start looking at the more intuitive approach. Now I know historically we've used a specific set of criteria for a diagnosis, such as decompression. Very commonly there's a classic decompression protocol, and we'll look at that in just a second. But let's move forward and let's consider outcomes versus diagnosis. So I use the analogy and actually the approach to as I would manual therapy in the extremities. And really, when we look at distraction, it's a form of long axis traction, and we can use it similar. The thought process, the approach that you would use long axis traction or a long axis traction mobilization technique in the extremities. So when people ask, what's a specific protocol for a specific condition, I think yes, there are some, but I don't think that there's a number of protocols for every single condition that's out there, versus it's based on what it is that you would like to accomplish. So I always ask someone, what would you like to accomplish by applying a specific technique? And I sort of view the application of mechanical distraction in place of what I would normally do with my hands from a long axis distraction standpoint. And I use the grading criteria, set by Maitland and Kaltenborn. They're very, very similar. Kaltenborn is specific to traction. And then we can also look at, some of these other patterns. We have more options today than we did, even 10, 20 years ago with the technology and the microprocessing systems to create specific pull patterns like we see in the DTS system. So I'm not going to cover all of these, but you're very familiar, I'm sure, with Maitland's joint mobilization grading scale, and how we have different scales that include different speeds, different intensities, and the intensity is also going to be related to the amount of mobility. So in other words, as you increase the gradient between a high and low intensities in intermittent traction, you will have more mobility, as well as the intensity increases, you're also closer to end range of a particular movement pattern. And when we can also set the time frame in between each stage of intermittent traction, then we can create certain oscillation effects. So this is not a new concept. There are different grades. One thing we still can't do is create a grade 5 thrust technique with a high amplitude. So even with devices, we can mimic the speed, but we don't have the amplitude that we can do with our hands. So probably the closest that we can get is a grade 3 with our distraction devices. And again, there are indications to use those. I think the difference, if you apply that process to the anatomy, the biomechanics, and the physiology, we have some slightly different indications in the spine than what we would see in the extremities. So in my opinion, there's really probably somewhere around 5 technique or protocols, and everything else is just sort of a variation from there. And that includes the patient position. What would you like to accomplish with the degree of mobility, and what type of mobility you would like to introduce from the patient. So I think when we look at acute spinal pain, and I always put goals and expected outcomes. So my goal is to decrease further injury, edema, and pain reduction. And that really doesn't matter, what the injury is. The approach is going to be very, very similar. And the expected outcomes from setting an appropriate set of parameters on my device should create a mobilization, decrease in spasm or hypertonicity, and some mechanoreceptor stimulation. And this is the same approach I would take for any of them. And because anything is static, I never use more than 8 minutes for a static treatment. Neurologically, those effects actually take place within the first several minutes, and so there's not much reason to hold them any longer. You can, and it won't be detrimental to them, but you're not going to get any more added benefit from them per se versus actually repeating that same session several times throughout the day. So the approach, the intensity is going to be very, very similar from one person to the next. And then we look at the subacute. And so the idea of looking at the subacute phase of injury is to start creating a tissue healing effect, further reduction of edema formation, and so we can set it appropriately. Now, a grade 1 Maitland mobilization does create some oscillatory effects, which can also be used during the acute stage. It's my preference as a practitioner. I find it's more beneficial to use a static pull pattern during that particular stage. So I will use typically static pull patterns at either end of the spectrum during the acute stage and when I'm trying to really create large deformation to tissue. So subacute is going to be a different pull pattern. So it's going to be intermittent, and the idea is very similar to creating ankle pumps. Personally, I use 5 seconds at the higher intensity and 5 seconds at the lower intensity. So we're introducing intermittent. We're trying to create some mobility, and potentially, depending on the intensity that you're using, you would also try and introduce some stress into the tissue to stimulate fibroblastic activity. Now, I put this one in here because in the literature, this is very classic as a disc herniation protocol, and what we see is a high and low intensity because it's typically intermittent. Suggestion is that we use the high intensity as the marker, so you determine what the upper intensity is going to be, and then the lower intensity determined by 70%. What that does is it minimizes the gradient, because if there's too large of a gradient, you may not actually get relaxation or suppression of muscle activity, because an introduction in a stretching effect actually stimulates mechanoreceptors and can actually create the opposite effect and stimulate mechanoreceptor stimulation that results in increase in muscle intensity. So when we look at some of those older protocols, and maybe the reason that some of them were ineffective was because they went from a high intensity all the way back down to 0. And that includes some of the studies done where they were doing an extension moment exercise in between, and without that ability to have an appropriate length of time or duration for the stepwise effect, the muscle may not have been able to relax, and you won't get to see the same outcome. And then what we see again in the literature is multiple level degeneration, stenosis, facet syndrome. It's very similar to the disc degeneration, and a lot of those studies actually used same subjects because they're multifactorial. So this is the protocol that I use at the later phase, especially in more chronic, multiple level patients, that we actually do want to introduce a greater degree of tissue formation and try and create some level of separation, and hopefully maintain that through a form of exercise activity. And then this is just an example of a mobilization technique, and it's an oscillatory, and depending on the speed that you set, you could mimic a grade 2, possibly a grade 3 Maitland mobilization. And again, it depends what the indication is. So you need to determine what it is that you would like to accomplish by an outcome and not necessarily a diagnosis. So in conclusion, we're not diagnosis specific with regards to the application, but it's more related to their condition. And what that does for us is it makes it outcomes based. So when we measure that, it provides us a better opportunity to create more application for a greater diversity of patients versus typically, traction historically was really used to pull people very, very hard, versus I have patients that will be on the table within hours after an injury using this particular outcomes-based approach. The sequence. So applying in a specific sequence, I put a lot of slides in here. I'm going to go through some of those very, very, very quickly, but I think that there's added benefit to using an appropriate sequence technique. And it started from treating some of my athletes, and that were very, very large, and to do some of my manual mobilization techniques could be relatively difficult. And so what we found was, especially following spinal distraction, it was easier for me to do some of my my mobilization techniques, which was really beneficial because I could use less force applied to the patient, and that was more comfortable for the patient, but actually required less force and energy from me as the practitioner, saving my energy to be able to treat more patients, essentially. So here's the basic sequence, and then I'm going to show some information that sort of supports this notion. We manage the pain. So I'm a big fan of light therapy, specifically laser, because the duration, the treatments are very, very short. It has a lot of good efficacy to it, but there's a lot of overlap. You could use electrotherapy, ultrasound. Hot moist packs are very popular for the patients, and they have a really high satisfaction and can be beneficial. So we get them comfortable. So then when I put them on the table, and it doesn't matter if you're treating cervical or lumbar, we can get them on the table more comfortably, and they're more apt to relax and stay in that position for an extended period of time. And as a result of this, I can get about 95% of my patients in that supine position I mentioned earlier that was really important to me. And I've been able to get 100% of my patients on the table in one position or another. And by using that approach of decreasing the pain, it also makes them more compliant, and they're more willing to do what the next level is. And then mechanical traction followed by manipulation. So either hands or using a technique or an implement. And like I mentioned, it requires less force, and potentially it might be more effective. And I'm gonna show you some stuff here in a second. And then all of those things lead to better movement. So if we can introduce better movement into the patient in an earlier phase, their therapeutic exercise, their movement is actually going to be more beneficial. So I do spinal manipulation, and what studies have shown is that manipulation and mobilization, so manipulation is a grade 5 thrust maneuver. It affects different sensory beds. So if you're doing manipulation and mobilization in the same session, you're not being redundant. So you're not doing the same thing twice. There's benefit to doing both of those things. So this is a particular case study. This is a female volleyball player, acute low back pain, injury. I'm just showing you the assessment method. So this was her being tested using what's referred to as a march-in-place test using my OptoJump system, and it measures some of the criteria, and in particular I'm showing you the flight times. So what we see in patients that are very acute, we tend to see a high degree of asymmetry, and then we also see a high degree of covariability. So in other words, on the side that's injured or responding mostly to the effects of the injury or the pain or the decreased in mobility, the disability, is there's also a high variability because they haven't been able to compensate for that, and that's what we're seeing here on this right leg. So this is her before she was treated. What we like to see is really less than 6% in the covariability. So that's the covariability statistic. Time in contact, time in flight, pace, and the cycle. Basically, that means that she can't repeat her pattern consistently. She doesn't have good motor control. So she was acute. So we did the acute protocol, which was static, 30 pounds for 6 minutes. And then this is her assessment following. So what we see is a dramatic reduction and almost all the way back to normal with regards to her contact time, her pace, her cycle. And then we're still seeing a slight change in her flight, but that was at 17% and it dropped down to 8%. Well, what does this mean exactly? Well, what it means is that if I did my exercise therapy before I did my mobility, is the motor control pattern is not going to be as good. So she won't be able to perform the exercises as appropriately as we would like her to, and that's why we see some potential added progression by using this particular sequence, and that sequence being doing the mobilization technique before we do the exercise or the therapeutic exercise component. So we've done a couple projects on this as well. So we looked at the effect of manipulation following lumbar distraction, and actually we published data on manipulation during distraction. So patients were under distraction while we were using a technique, and in particular we used the neuromechanical innervations. So Chris Coloca, Dr. Coloca sponsored our project, and so we were very, very pleased with that. Basically what we did was we did a couple things. So this particular one I'm going to show you was we used static lumbar traction at only 40 pounds. We used surface EMG, and we looked at the trapezius as well as the erector spinae. And a couple things we just did really for interest's sake was we looked at the effect of the manipulation at different areas to these particular muscles, and you get a couple things from that. You get some noise because it's going to be a surface EMG, and then also what typically happens in people that are asymptomatic, you tend not to see dramatic changes, and so that was pretty interesting, you know, with these folks in particular. So this is just a normative value in looking at the influence or the electromyotic activity during standing, bending over, and shoulder shrugging. As you can imagine, the middle trapezius should be very, very high. And this is the activation compared to standing. So we're looking at standing, pre-traction, so they're in the prone position, and then we have progression. And what's interesting, when you don't use an appropriate stepwise pattern, what you see is an increase in muscle activity, and that's a discussion for another topic or another day. And then after we hold it for a period of time, it starts to go down. But as we increase the intensity, you start to see an increase in myoelectrical activity pattern. And that's why the time at which you hold your steps is actually going to be pretty important. And so that number does go down after you hold them for a period of time. But in symptomatic patients, that could actually be a relatively long period of time. So what we see here, activity during the various treatments, and I'm going to skip to this next slide here too, is, you know, we see some dramatic changes during treatment, and that's very common. So when we measure during the actual application of the manipulation, we tend to see really, really high spikes. And that's very common because neurologically that's what's happening in the response to a very high stretch. What's interesting is if it's rapid enough, unlike a deep tendon reflex, if it's rapid enough, it actually has the opposite effect and causes muscles to go into a state of relaxation. So what we found was we saw a decrease beyond traction with the application of manipulation. We found that during. We also found that after, and it was actually a little bit unusual because we don't always see that in asymptomatic patients, especially when you're measuring electromyography versus H reflex, for example, and actually assessing motor neuron pool. So what we're able to determine is that we get an added benefit with the manipulation along with the distraction, and so we get further relaxation. Or basically what happens in the case of patients is we see a change in the neurological pattern that results in enhancement to, as I showed earlier, motor control. We also see in those patients, and this has been shown both in the upper and the lower extremity, and we did another study with lower extremity in traction and showing the influence on the Hoffman reflex. But what happens is it suppresses nociception, and we see an immediate improvement in the latency response to motor neuron activity in performance in the lower and the upper extremity, which again further explains why we saw that enhancement to motor control. So we're not being redundant, and in fact we're being more beneficial by applying it this way. And so that may actually influence the motor patterns or make their therapeutic exercise more therapeutic.